So Ali, I'd like to turn to imaging now, imaging technology. How has imaging technology changed the diagnosis and treatment of Alzheimer's disease?
Yeah, so I think imaging is really exciting, and other biomarkers. So we have fluid biomarkers and neuroimaging that are really allowing us to have much better accuracy in diagnosing this in life. So it used to be that they said, well, you can't diagnose it until someone's passes away. We have brain tissue. Now, using sort of an algorithmic sort of multi-tiered approach, we can actually see if people have the pathology in their brain, and if it's in the right clinical setting, syndrome, it's more than 99% accurate. So I think about it a different way. So if you think about the category of structural imaging, which is something that is almost part of almost all guidelines, that allows us to both exclude and include the diagnosis. How do we do that? So we look at other sources of brain injury, vascular brain injury, and tumors. They happen, but they're rare. And the caution about that is to make sure that you have an understanding that just because the reading comes back on an MRI that says age-related changes in the white matter and atrophy, that doesn't mean that there could not have been neurodegeneration, and this doesn't have Alzheimer's at the other end of it. One good scan, MRI, that allows us to look at atrophy patterns in Alzheimer's disease. Oftentimes it could be the mediotemporal lobe hippocampus or the parietal lobes can be shrunken early. If that's there, that's very, very suggestive of neurodegeneration. Then we can think about in specialized cases, we can look at FDG PET for metabolism. So again, in Alzheimer's disease, there's a typical temporal and parietal hypometabolism where basically the brain is not revving correctly. And then right now, we also have amyloid PET scans that can tell us whether there's plaques in the brain, and those are relatively accurate. The issue with that is that it's not really reimbursed by insurance very much. Some VAs will actually apparently pay for that. But going down the path, I can tell somebody who really wants a high level of certainty if they have Alzheimer's disease, doing this algorithm that actually it's due to Alzheimer's disease by doing the cognitive profile, doing the blood work, doing the MRI, and then I shouldn't forget the spinal fluid, which is something that isn't done as much in this country, but really can give us information whether you actually have the pattern of amyloid and tau in your spinal fluid that's consistent with Alzheimer's disease. That's very accurate diagnosis.
Anybody else have a different approach to using imaging, or is that pretty much your approach? Use MRI first and work down towards more complicated imaging, and of course amyloid
if
imaging.
You need to. Yeah.
Amyloid imaging, very expensive, so out of the reach.
I'm starting to use the NeuroQuant software or volumetric software more so than I did in the past, and I find it sensitive but not specific. So if you have significant atrophy in the hippocampus, I find it to be informative, but if you don't, it doesn't mean there's a problem.
Right.
And so that's the thing about it.
Yeah.
And of course, atrophy can be a consequence of many different types
Correct.
of neurological disorders. So it doesn't establish Alzheimer's, but I also agree that it's very helpful. I find reassuring if I've seen a hippocampal type of memory impairment, and now I've got hippocampal atrophy on a quantitative volumetric scan. That's helpful to me.
Right.
I take a little bit different approach. Certainly, I think every patient getting a first diagnosis needs to have an MRI to, as you say, mostly rule out other causes of cognitive impairment. And if you see, some hippocampal atrophy, that's great. Sometimes you don't. And but not so. I think for the straightforward, typical presentation, you don't need an amyloid scan, and it's probably about $7,000. Mm-hmm. I think that for atypical presentation, amyloid scan will be very helpful. FDG PET is very helpful to make the differentiation between Alzheimer's disease, frontotemporal dementia, Lewy body dementia, which can all be done with, if you're lucky, with FDG PET, and certainly amyloid scanning if the patient is able to afford it or if their insurance covers it. But otherwise, as I say, for a typical presentation, it's really not necessary, I don't think.
The interpretation is really important again, because oftentimes if a clinician gets the report back saying, age-related changes, to then say that that can't be Alzheimer's disease is wrong. So that again, the positive predictive value is really, really high. And to my eye, when I look at these scans myself, oftentimes what is read as age appropriate is actually really not so much. You can actually see clear patterns of atrophy to my eye in areas like the parietal lobes or mediotemporal lobes that aren't called. And FDG PET, I think, again, should be reserved for special cases. But again, I find many reads not to be quite accurate. It has to be quite severe for somebody to call that as hypometabolism, where to my eye, it's pretty clear that there's hypometabolism. So there's caveats with that.
And I've seen the opposite as well, where people were diagnosed as having Alzheimer's, and really the scan was unconvincing, and when repeated was normal.
I wanted to add that FDG PET, there's a paper by Jagus years ago suggesting that the higher the mini mental, meaning the closer to 30, the lower the sensitivity of FDG PET. And so you really, if you're in the 25 and above range, you may have a false negative, when in fact you need to go a little bit lower.